Okay, with that, I think we will ask everybody to turn on their video and unmute themselves. And we have with us also Dr. Yvonne Borello, who will join us in the second session. So the four of you can answer these questions however you like. We can have multiple responses. If you start seeing that we have too many questions and you don't think we will be able to answer them in time, maybe some of you can jump in and answer some of those questions. Okay, we had a question from somebody on iberdomide. So Dr. Bodros, maybe you want to take this one. Any idea if the cost of iberdomide will be the same as the first generation IMiDs, and are they oral?
I have no idea. Yeah, it's an oral treatment. It's very much, as I said, similar to lenalidomide and pomalidomide. I don't know anything about the cost. I have no idea. I know that's an issue for patients. I'm aware that Revlimid increased in price this year. Unfortunately, these are things beyond our control.
Mm-hmm. And Siam had a kind of related question that Revlimid or lenalidomide isn't effective in about 40% of the population. I'm not sure if that's true for maintenance therapy. So do you think these cell mods like iberdomide and others that are in development, and there are a lot of them, it seems like, in development, will they be used as maintenance therapy as a replacement for, because I understand they have lower toxicity and more efficacy?
I think lenalidomide have shown significant activity as maintenance, actually. It's probably one of the most effective drugs we have as maintenance. It improves remission duration by almost a year and a half compared to transplant with no Revlimid. I think the question for maintenance at this point is not replace Revlimid, but can we add more to it? So as you know, there's a trial looking at daratumumab in combination with Revlimid, looking at MRD testing. There is a trial looking at addition of some carfilzomib in high-risk patients. Will IPER end up being in maintenance? Probably it will, how drugs develop. But I think at this point, Revlimid is really the main drug and standard of care for maintenance in myeloma.
Mm-hmm. Okay. Anybody else have a comment on that?
No. We agree with Ashraf always.
I think we all agree.
And that's all fine. Okay, I have a question about CAR T therapy, and maybe several of you can weigh in on this. When you think about stem cell transplant, you think about induction therapy, kind of debulking the tumor. And then you get the stem cell transplant, and you might do consolidation to kind of continue that response. Is the purpose of the CAR T, and I know these patients who are in clinical trials have progressing myeloma, and so, maybe this is a dumb question for that, but when you think about using CAR T, are you thinking about it as a tumor debulking tool, or is it doing something completely different? So like as a strategy, would you debulk the tumor with maybe a triplet combination and then send a patient to CAR T and then try to maintain the response with something else? I guess that's my question. How do you perceive CAR T when it comes to the debulking of the tumor idea?
Sure. So I'll take a crack at that, and then I'm happy to hear what my colleagues think as well. So I think the current studies and the initial approvals are going to be for patients who have progressive myeloma, as you said. I mean, that's going to be for refractory patients who have progressed. And so those are going to be patients with, unfortunately, probably growing disease, and the CAR T cells are going to be used to really try to get that under control and do the bulk of the heavy lifting to sort of get it in remission. But there's definitely data coming out that, patients with better disease control going in, perhaps with lower tumor burden, may have lower risk of severe toxicity and severe CRS and neurotox. And that's being borne out in some of the B cell cancers and in some of the myeloma studies. So I do think in the future, and there are already studies looking at this, using it as a consolidation approach may ultimately make more sense when you've already debulked the tumor with induction or triplets or something like that, and then come in with the CAR Ts to mop up the rest. Maybe perhaps a safer way to do it and really get to that MRD negative state. And so several sort of phase 2 studies are already ongoing, doing exactly that, where patients get initial therapy and then they move on to CAR T cells to try to sort of do it rather than waiting till the disease is growing.
Yeah.
So I hope that answered your question. I think you're on the right track there, and I think that may be a smarter way to do it ultimately. I think in the beginning, though, it's not going to be approved in that indication, but we'll get there.
Well, you are experts in this field, and I mean, a lot of this came out of UPenn, so thank you for answering that question. And you have such deep expertise. And then Dr. Rajay, I know you've done a lot of work on the BB2121 trials. Do you have any comments on that in terms of, because what you're saying is lower side effect profile, maybe with a lower tumor burden going in. What about efficacy? Like when you're looking at these trial results, are you seeing patients who had a lower burden have lower or better efficacy too, or longer duration of response, or?
Yeah, so I think those are all good questions, Jenny, and I agree with Adam completely. I do think there's more and more evidence now in the myeloma space also. This has been borne out in lymphoma for sure, but there's more evidence in myeloma as well that doing it with a lower disease burden, number one, is you're going to have less toxicity, as Adam has pointed out, but also better efficacy because it's going to allow your T cells to expand. Doing it early, so when we first started using CAR T cells and the data you are seeing now with both cilta-cel, ida-cel, or even orva-cel, is the fact that these are heavily pre-treated patients. And for us to actually see the kinds of response rates we're seeing in really heavily treated patients is proof of concept, and the fact that we're seeing these robust responses to me is incredible. So the question is, if we bring them up earlier, are we going to do better? And most of us would expect that to be true. Whether that bears out or not is something we have to wait and see. So we're already doing those studies, and what we are focusing on right now is obviously the high-risk patient population. So for example, ida-cel is being tested exactly the way ida-cel as well as cilta-cel are being tested exactly the way you've sort of alluded to. You get a triplet initially. If you have high-risk disease, you will be consolidated with a CAR T cell approach, and then you're allowed to use maintenance following that maintenance of your choice. This is an ongoing trials actually, and patients are accruing, and hopefully we'll know whether or not we have changed the natural history of high-risk disease there.
Mm-hmm. So many questions to be answered. And Dr. Borrello, as an immunologist also, do you have any comments to weigh in on that and maybe ask one of these, answer one of these questions? Kathy and someone else had another question about an age cutoff for CAR T.
So I would like to add to what Nupur just said. I mean, I do agree that clinical trial development starts with the most heavily pretreated patients, and if you see efficacy move up front. I think there are a few benefits to integrating CAR T cells earlier on. One is the lower disease burden, as was just mentioned. But I think the other one that we tend to not think about too much is the fact, and I think we're probably fortunate in myeloma that we're really not truly using chemotherapy in the sense of cytotoxic chemotherapy as much as we used to. But it's clearly been shown that the more therapies patients, at least cytotoxic therapies that patients are subjected to, it ultimately results in significant dysfunction of T cells. Now, certainly IMiDs have been shown to actually enhance T cell function, but steroids don't, proteasome inhibitors don't. And so I would assume that the benefits of moving up front would be a combination of a lower disease burden, like Nupur just mentioned, but also the fact that you have a healthier T cell that can more effectively do what it's supposed to be doing.
Mm-hmm. Okay, so that was kind of the general theme or the feeling that I got out of ASH was, wow, we really want to move these immunotherapies, whether they're the BiTEs or the CAR Ts or the antibody drug conjugates, up way earlier to see how patients do. So that's exciting. Adrian had a question: how does response rate compare between BiTEs and CAR Ts? So I would invite you all to jump into that question.
I can get started if you want, Jenny. You know, the good news is the BiTEs are off the shelf, And what we saw at this year's ASH, and I think you're going to discuss BITE in the session after, but really high response rates where you're seeing MRD negative disease as well. The problem, so you're seeing in excess of 80% response rates with bispecific T-cell engagers as well. The issue with BITEs right now is the numbers are smaller and the follow-up is shorter. And the difference here is, whereas CAR T-cells is one time and done, BITEs is something which we're doing sort of continuously. You start off once a week, sometimes once every other week, and we're still trying to figure out what the best way of giving this is. So I think both of these are very promising strategies with extremely high response rates, despite us using them at the tail end. Just to echo what Yvonne said, is the earlier that these come up where your T cell function is normal, the more effective they're going to be.
Mm-hmm. Great. Okay. Michael had a question that was emailed in about being triple class refractory. So if you're triple class refractory and the main myeloma drugs are not working for you, Dr. Badros, you showed some kind of branches of different, at first relapse and second relapse, what you might want to consider. So we can go back to you and you can help answer this question, but what do patients consider after they become refractory to the three main classes of myeloma drugs, which are like proteasome inhibitors and IMiDs and probably monoclonal antibodies, right? So
I think at this point, probably a clinical trial definitely would be first, either IBER, which is available only on clinical trials. I think that was a comment made, or if they are not available, or clinical trials are not available, then they can go on belantamab, which is a approved drug. The catch with it is going to be the monthly eye exams. CAR T cells will definitely be an option. I think what will decide which one we will go on is availability of treatment. Most of those treatments are not available everywhere, and how fit the patient is. I think we talk about all those drugs as equal, but they are really not. Each treatment has a lot of side effects. And I think we are learning how to manage them. I think you mentioned selinexor in the beginning. It sounded like a drug that should not be used by anybody. And as time went by, we learned how to manage the side effects. So I think that's the same will be with belantamab, with the corneal toxicity. And I'm sure CRS is managed much better nowadays compared to when the lymphoma folks started doing it. So I think things are heading into the right direction. And I just want to mention, in addition to the CAR T cell and all the immune therapies, I think immune therapy success is giving patients a long-term remission. I think if you are going to talk about allogeneic transplant, the classic immune therapy or CAR T cell or all these treatments, their success is not in using a response. It's actually how durable that response is. And I think having a treatment-free interval is one huge plus for CAR T cells. That being said, as Napur mentioned, there is some trials now looking at maintenance and DARA and Revlimid after the CAR T cell to try to prolong the remission duration. So I don't know how that will impact the benefit or the subset of patients that don't need any more treatments. I'm aware of patients that are 2 to 3 years out in complete remission after CAR T cells.
Well, we're all very excited about like a one and done approach. That would be really awesome. Okay, Mary has a question about CAR Ts. She did CAR T in 2018. She's still MRD negative. And it relapse, is there a way to determine if it's caused by persistence or loss of BCMA to determine her next therapy options? And Dr. Cohen, you kind of referred to this at the beginning, that we would probably see some questions about this. Do you want to take a shot at that question? Sure. And I'm sure others will want to weigh in.
Yeah, so I think this is really still a very emerging area of research, but there definitely now have been a few reports of patients who got BCMA CARs or even bispecifics, and when they relapsed, their myeloma no longer was expressing BCMA. So the tumor unfortunately had escaped in some way, a mutation had developed, or they'd lost the gene expressing BCMA. That has not been the majority of patients, at least described so far, and we've seen several patients where BCMA goes down temporarily, but then comes back up. So I do think that the mechanisms of resistance to these therapies is something we need to understand more. In some patients, it may end up being BCMA loss, and then another BCMA therapy may not be useful for that patient. But in many others, BCMA is still there, and then you can go on to belantamab or a BCMA BiTE or other things. So what we need is a sort of robust way to assess BCMA that's widely and broadly available. And that, unfortunately, is what we're lacking, at least something commercially available. I think each institution has its way of assessing BCMA, and we can do this for some of our patients on clinical trials. But it's not there for the community oncologist to just order right now yet. But I do think that's something that will eventually be necessary when we have all of these BCMA modalities available to us.
Mm-hmm.
So anyway, I'll stop there.
Anybody else want to weigh in on that? I know some like BiTEs are going after some new targets. I can never say it right. Is it GPR5CD or something like that? There's another one that's F something.
FCRH5. Yep.
Yes, I need a name. But anyway, going after these as secondary targets potentially if CAR T doesn't work or you lose the BCMA expression or whatnot. Anybody else want to comment on that?
I was just going to add that there are other targets, Jenny, as you pointed out. And the other thing is we also have in clinical trials as we speak, modality treatment strategies to increase BCMA expression, for example. So those are ongoing trials and we are looking forward to seeing what they look like. But I do think GPCR5D as well as the other one, FCHR5, even we can say it, but yeah, all of those are targets which show a lot of promise right now.
Yeah.
Can I ask a question? So do you think there is a possibility of doing CAR T cell using BCMA, and then are you able to collect T cells after that to go for a second CAR T cell against another target? Because all those trials exclude prior CAR T cell. I think it would be difficult. I think you will have one shot at a CAR T cell. Is that correct?
So it really depends on the trial, and some of the trials we have open do allow prior CAR Ts, and there have now been published anecdotes or in some small studies of patients who had one CAR, they relapsed, they got a different CAR, and they responded. So so I don't know how this is going to play out sort of in the commercial world and once they're available, but I don't think it's impossible to do it twice. I don't know how often that's going to happen in reality when we have so many other options, but it's been done.
And I think we can take it from the lymphoma world, right? There are so many different CAR products which are approved in the lymphoma world. And if you relapse to one, like Kymriah, for example, you can use Yescarta and people have seen responses. So I do think some of that is going to happen with myeloma as well.
Mm-hmm. Okay, great. We have a bone question for you, Dr. Rajay, from Anil. If a patient has osteoporosis before diagnosis of myeloma, what's the right strategy for bone strengthener usage with lytic lesions or bone problems at diagnosis? Like, do you do continuous limited duration what's the strategy?
So, if you have active disease, we do believe in using bone-targeted agents continuously. I do think over time we reduce the intensity of the bone-targeted agent. And if you have just osteoporosis, again, use osteoporotic doses. So you can use drugs like zoledronic acid every 6 months, for example. You can use even drugs like denosumab or Xgeva, which is given every 6 months. The important thing to remember is if you're on a drug like denosumab, do not stop the drug because you're going to get a rebound effect. And in those patients, you either use a drug like Zometa at the back end, or you sort of do it less frequently, continuously.
That's a very important comment. I'm really glad you brought that up because a lot of patients and a lot of even clinicians don't know that. So that's important. Okay, Pat is asking, how do you decide whether to try CAR T versus BiTE versus the antibody drug conjugate? What factors will help in making this decision? Dr. Brella, do you want to start us off with that?
Well, I think oftentimes in practical terms, at least right now, prior to FDA approval of a CAR T. It's a question of convenience and availability. I can also tell you, and I think Ashraf alluded to this, one of the benefit of non-individualized therapy is that it's an off-the-shelf product. And you could theoretically talk to a patient about it today and start the therapy tomorrow, which is obviously something that's not the case with regard to CAR Ts. But you know, there is a benefit that a CAR T cell therapy can potentially offer a more durable remission, and certainly with a lot less therapy along the way. The benefits of the antibody drug conjugates, I think, is that you have, you know, an immediate therapy that's available. I think there's two mechanisms of killing. There is a lot of evidence. We talk about the fact that with belantamab, there's a drug that binds, and so you can deliver very high concentrations. But what's also evolving from the therapies that are the studies that are being done with belantamab is that there's this phenomenon known as epitope spreading, that basically when a cell is killed, when a tumor cell is killed, it can be killed in an apoptotic or a necrotic manner. And a lot of people have studied how cells die. And it turns out that apoptotic cell killing is highly immunogenic. And the benefit of that is that in addition to getting direct killing from the tumor cell, from the drug itself, it also elicits a T cell response. So you get the spread of an immune response that can occur. There is evidence that belantamab can do that. Now, there's also evidence that the way T cells kill in general, so CAR T cells are probably doing that as well. But these are things that I think show that it's not necessarily stuff that you can put into a box. And overall, sort of like what's emerging right now with the COVID vaccines, I would say to patients, if they're desiring a B cell type therapy, I would go with whatever's available first. And, you know, considering that there's probably going to be the possibility of getting the other ones down the line.
Mm-hmm. Okay, great. There's a lot to think about as a myeloma patient. That's why we go to you. I think this just stresses the point, and I always stress this point, is myeloma patients should have a myeloma expert on their team. So it's really clear that myeloma is quite nuanced. You layer something like COVID on top of that, and then that's even more nuanced. And I'm going to jump to some COVID questions, but always see a myeloma specialist, especially when you're making treatment decisions at that time point, and especially when you're newly diagnosed. Make sure you get all the right tests. Make sure, because the experts like these will run these tests, and I'm just so grateful for all of you all the time. I always want to cry almost after we do these, because I'm so grateful for the expertise that you provide and the fact that you've dedicated your lives to helping us. Gary has a good question. Can the J&J vaccine for COVID be taken later if you've had the Pfizer one? And then, like, if you get COVID, how long do you wait to have the vaccine, or do you? So those two questions. Let's start with those.
Well, I think with regard to the waiting after infection, those are guidelines. And I forget, and maybe some of you know, but it's either 6 or 8 weeks after the infection is when you should be getting the vaccine, and not sooner.
Okay, I didn't know that. And then what about doing the J&J vaccine if you've had a single dose or double doses of the Pfizer or the Moderna?
So doing the second with J&J after you've had Moderna, or I wouldn't do that right now. I think let's get everybody vaccinated. There's no data whatsoever, and with either the Pfizer or the Moderna, you're getting a 90+% immune response in the general population. What we don't know right now, and these are things which we are studying, is what happens to myeloma patients. I think the important thing to remember is whatever vaccine you get access to, whether it's Moderna, whether it's Pfizer, or whether it's J&J, once it gets approved, I would say yes to it. We have ongoing studies, and I see Ajay has joined us as well, and I'm sure he can chime in, is wherein we are looking at antibody responses, because people are going to have different antibody antibody responses depending on their level of immune paresis, as well as depending on where they are in their treatment paradigm. The International Myeloma Society is going to put out guidelines specifically, and the few things that I think we have to be careful about is transplant and immediate CAR T cells. So for immediate CAR T cells, I think what we've said, and Adam jump in here as well, is 3 months post CAR T cells is when you can potentially get a vaccine, because that's when you've had sort of immune recovery. For autologous stem cell transplant, most vaccinations happen after 6 months. But outside of that, if you're not neutropenic, we are recommending the vaccine. I think the bigger question is, do you hold treatment while getting the vaccination? I think most of us on this panel would agree, if you're on an IMiD, there's no reason to hold the IMiD, because if anything, the IMiD actually augments your immune response. That's lenalidomide, pomalidomide. For other drugs, I don't think we have data, and I'd love to hear what other people think as well.
I was just going
Go
to
ahead.
add that from the myeloma vaccine perspective, I don't think there's a safety question, but the efficacy question is the unclear issue, because a lot of patients with cancer or chemo were not included in those studies. But what I can tell you is that at Sinai, in the first wave, out of 23 patients with myeloma in whom we tested for antibodies, 22 actually had antibodies. And that's pretty striking, considering the median age, being on CD38 antibody therapy, having low IgG levels, because to mount a response, you need good plasma cells and an IgG production. So I was actually struck by that number, which I think bodes well for the vaccine, because the vaccine is supposed to generate a better response than the actual infection. So I think we're really encouraging everybody to get it as soon as they can, whichever one they can. And I don't think we have data about sequencing. And we've been basically following exactly what Nupur said, waiting for the post-transplant setting. But the other patients, I think steroids you can always hold for a week. I think that's easy. And the other important part is also the disease control, right? So people with uncontrolled disease may not even be able to mount a good response. So that's one nuance, and you don't want to compromise disease control. And on the other hand, in somebody who's really well controlled, is skipping a dose as big a deal? So it's hard to have a blanket statement of one size fits all for all drugs for all patients.
Mm-hmm. And that was one of the questions, like, do you hold steroids after the fact? Because I know they do depress the immune system. So that was great to have you cover that. Thank you.
Go ahead. Just a quick question. So a lot of patients are asking if they should check antibody responses after vaccination. The CDC recommends not checking antibodies after vaccines. What do you guys think? And the question is going to be, so what do you do if they are negative? And I know that antibody is part of the story. We have probably more immunity with the T cells. So what would you recommend?
So I'm just going to add one thing here, Ashraf. The routine antibody test does not actually pick up the antibodies to the vaccine, because the vaccine is against the spike protein, and that's not the routine test we're using. It's a blanket test, which is testing for antibodies. So routinely post vaccination, I don't think necessarily people need to test. But if there are studies which are ongoing where we are going to have a study looking at specific immune responses to answer some of the questions which Ajay is asking, I think that needs to happen. But just blanketly checking because you're not checking for the right antibody shouldn't matter.
And I think the answer to that kind of question, whenever a medical student wants to do a test, you say, well, what are you going to do with the information, right? How will it change your management? And I think with such limited data, I don't know. We certainly don't have enough vaccine to revaccinate people if it was negative, and that we don't even know if we're checking the right test. So I think right now it's very premature to be checking antibodies, especially to guide any management questions.
Mm-hmm.
That's important. I think it's good to know. So CAR T cells, we all agree that it will be about 3 months after CAR T cell. How about stem cell transplant? When do you think we should vaccinate those patients? 6 months is what we do. Shingrix can be given at 60 days. What would you recommend for COVID?
Right.
So at Hopkins, we're doing 3 months, and I think the CDC came out with guidelines saying 3 months following autologous.
Mm.
But I was going to bring up the Shingrix trial, Ashraf, because
60 days, yeah.
that was done at day 50 to 70 post-auto.
Yeah, so I think 60 days should be safe. I know CDC said 3 months, but do you think we can vaccinate earlier than that?
We're debating that amongst ourselves, and some are saying 90 and some are saying 60, even for CAR T, just because we need to get this into arms, these vaccines into people as soon as we can. So
Right.
it may be individual decisions at each center, but I think 6 months is too long.
Yeah, it's not a safety question. I think it's a question of efficacy.
It's efficacy.
It's a question of, are there enough T cells and or B cells during the period of immune reconstitution to actually generate a response? And it may be suboptimal, but I think to Adam's point, it's better to get a 50% response and potentially prevent disease than to wait to get an 80%, but have that many more patients get sick.